तो ऑनलाइन मैं ऑलरेडी ज्वाइन करा हूँ देखा ना उसके बाद ऑडिट कर लो यार ओ कोड देना आउटपुट म्यूट के निविता निविता
हाँ जी सर, गुड आफ्टरनून। गुड आफ्टरनून सर।
You want to good afternoon, Minata. Just we are just starting.
Sure sir, sure sir.
ये तो तैयार ही नहीं करते कुछ। मैंने बोला था जब कुछ सब तैयार कर दो। तो ये भैया बस चेयरपर्सन है तो ब्लूटूथ सुनेगी उसको। तो ये पहले से होना चाहिए जब जब चेयरपर्सन। हाँ
Good afternoon, everyone. I welcome you all to our monthly scientific meet. So, the first case of interesting case of presented by Dr. Preeti Mohan. She is senior consultant Panis Hospital, Vaishnavi. Chairperson is Dr. Himanshu Agarwal, senior consultant Department of Max Patwardhanj, and Dr. Anvita Agarwal, associate consultant infectious disease, Sir Gangaram Hospital. Dr. Anvita will be joining us online. I request Dr. Preeti kindly start our presentation.
No. But today is actually consultant. We are colleague at Paris Hospital, Vaishnavi. I think it's the first presentation today in this.
It's not only a first presentation. Actually, I've been presenting. I haven't presented for a very, very long time. So, sir insisted that I should present this case because it's a very interesting case. I feel more like a resident now presenting after such a long.
Case and we showed me up. So I thought that this should be presented because sometimes patients pick up with some diagnosis and I think fever is a headache sometimes.
Yeah, definitely. Yeah. So sometimes in the cases, yeah, such patients are definitely. And I appreciate this patient for staying so long with me. Exactly. And considering that our center is not a referral center per se, we are a smaller setup. So the patient had trust in us and in me that, finally, yes, we'll come to a diagnosis. And she really stuck to us. And thankfully, yes, we were able to come to a diagnosis. Correct?
Hello? Hello? Yeah.
Okay. On clinical examination, when she presented, she was conscious oriented. On presentation, she had a high grade fever of 104 with a pulse rate of 120. Her oxygen saturation was normal. She had pallor, but her lymph nodes were not clinically palpable. She had a rash. Her throat was congested, but her tonsils were normal. Otherwise, her systemic examination was normal. This is the rash. If I don't know if you can appreciate it on the picture. Is it appreciable? The slight pink rash. This is in her forearm. The rash which you can see is in the forearm. So rash was non-tender. It was not raised above the skin. It was not palpable. The rashes usually used to appear during the fever in the extremities. There was no rash in the body, torso. It was only in the peripheries. It was non-tender, non-palpable. There was no associated itching or any other symptoms with the rash. And she was very fair-skinned. So initially we actually thought it was just an erythema associated with the fever. Now, so this was a history of the patient. So it was a typical PUO with 3 weeks, more than 3 weeks of evaluated outside, but with no conclusive reports. So then this is how she presented, and then we started evaluating her once again to find the diagnosis. So her investigations revealed anemia with a hemoglobin of 8.2, TLC of 12,400 with neutrophilic leukocytosis, a platelet count of 4 lakh. Her PS showed hypochromic microcytic anemia with neutrophilia, but there were no abnormal cells, no monocytosis. Her KFT was normal. There was mild raise in SGOT, SGPT, but her rest of her LFT was normal. Her sugars were normal. Her urine routine was normal. Her cultures were sterile. We didn't expect anything because she was already on multiple antibiotics. Her PCT was mildly raised. Her CRP was 72. Vidal was 1 in 160 positive. Typhoid, what I have not mentioned, was negative. We even got a scrub typhus, malarial antigen. Some of the reports are not mentioned, were negative. Her chest X-ray was normal. Her ultrasound revealed mild hepatomegaly with grade 1 fatty liver. Her viral markers were negative. So then we went ahead with her autoimmune markers because most of the tests were normal. We even got a thyroid done because she was complaining of some sore throat to rule out thyroiditis. Her free T3, free T4 was normal. Her ANA was negative. Her anti-CCP was negative. HLA-B27 was negative. Her calcium was normal. The ACE was done at a later stage, but I mentioned the blood tests together. Her ACE was mildly elevated, but it was not very significant. Her ferritin levels were very high. It was more than 1,000. Her ECG and ECO was normal. So from these blood reports, we could just make out that there was some inflammatory process going on in the body. Since the PCT was normal, a sepsis was virtually ruled out, but there was definitely some inflammatory process going on, but all her rheumatological markers were negative. And nothing could come out in the chest X-ray or the ultrasound, the cultures were negative. We had empirically taken her up because she was on multiple antibiotics already, so we had empirically started her on meropenem. And we were giving her antipyretics and NSAIDs as per requirement. But her fever was hardly touching normal. It used to go down to around 100. And then every day she used to have at least 3 or 4 spikes of fever touching almost 104. And so then we went ahead with a CCT chest and abdomen to look out for any focus, for the infection. So in the CCT, mostly the lungs were normal. So, and there was some lymphadenopathy. I'll just show the cross sections. So there was some lymph nodes in the mediastinum. In the abdomen also, there was some retroperitoneal lymph nodes, but there were significant lymph nodes in the right axilla and the left axilla. The right axillary lymph nodes were significant, around 3 into 4 centimeter, if you can sort of make out in the lymph node cross section. So this was the report of the CT. The lungs were almost normal, but there were mild mediastinal lymphadenopathy and a significant left axillary. This is a misprint. It was a significant right axillary lymphadenopathy of almost 39 into 28 millimeter. The abdomen also showed similar lymphadenopathy, but they were centimetric or subcentimetric lymph node. So with this in hand, we planned for a true cut biopsy from the axillary lymph node.
So I think Dr. Nita is also online. So Dr. Nita, what does she think about regarding all this? Dr. Nita, could you hear us?
Dr. Anvita, can you?
The voice is breaking. Can you repeat the question, sir?
What do you make out from all these findings that you have shown?
So as of now, we have a young female with high spiking fevers with more of inflammatory response. Ferritin is very high, CRP is high, with some non-specific rash. Does not clearly fit into any vasculitis up till the workup as of now, and is having mild mediastinal lymphadenopathy, but significant axillary lymphadenopathy. Whether reactive or infective, this is to rule out. So in my head, although an initial viral etiology with a secondary inflammatory response like picture will be the first differential. Second differential could be a partially treated long staying tuberculosis in view of lymphadenopathy. It could be something like histoplasmosis also, although rash in histoplasmosis is very rare. And other things in a young female, I would definitely want to do more vasculitis markers like ANCAs and ANA profile. Although lymphadenopathy might also prompt towards sarcoidosis, but axillary lymphadenopathy goes against it. I would also want to look into things like EBV and maybe CMV, which can give a prolonged fever with pharyngitis, with mild lymphadenopathy and rash-like picture. So I guess first differential would be viral, followed by chronic granulomatous diseases like TB or histoplasmosis. What would you suggest, ma'am? What were your differentials at this point of time?
Yeah, even like for the even we were considering like since the throat, we asked the ENT also to evaluate for the throat, because that was one thing which was in the mind. But one in the peripheral smear, there was hardly any mononucleosis. It was just neutrophilic leukocytosis, and her throat was absolutely normal. There was hardly any tonsillitis that way. So we were not thinking on that lines much. And as far as vasculitis was concerned, there was hardly any, like the urine was absolutely normal. There was no kidney involvement, there was no liver involvement. Considering that the patient was supposedly having a vasculitis involvement, there should have been some positive finding. The rashes also were it was not a typical vasculitic rash. So that was one reason we didn't specifically go into a vasculitic marker. Like, of course, the ANA and all was negative. We did get an ANA done, but we didn't go in for ANCA markers because even the CT didn't show any changes in the lungs. There were no positive findings otherwise.
I think
So,
CBV
yeah.
and CBV was not done. CBV and CBV
We did it later.
later.
Yeah, we did it later on the biopsy.
What is your take on this high CRP with no high ferritin, with certain joint involvement and structural rashes? So definitely we have a lymph node also, and tissue biopsy definitely
Yeah.
should be done. So in your mind, what would be your definition at this point?
So I think should always rule out vasculitis. So since some patients they present with fever and ICRP and inflammatory markers, so it doesn't have any ENT manifestations, no symptoms of sinusitis, ear involvement, no
No
vascular
high involvement.
But as a part of so the disease which is coming to my mind, I think everybody must be thinking the same, but many of the so I am thinking of autoinflammatory disease at this point, but that is a diagnosis of exclusion. So I also do a PET scan. Usually,
Yeah.
I prefer a PET scan because sometimes young female large vessel vasculitis we might miss although she has,
But there were no signs of large vessel. Again, there was no signs of there were no signs of large vessel vasculitis in this patient. Like BP was normal in both hands, and it was more of
yeah,
like-
since it's a diagnostic exclusion, so we should go all out before labeling autoinflammatory disease. Upstream virus, yes, it's always a
EBV. We did in the biopsy. We did check for EBV.
So I think just PET scan should be.
So we did go for a PET scan, but the order got reversed because at this point of time, I was more in the lines of an infective, more of tuberculosis. So maybe the order of investigation, we did go in for a PET, but yeah, I'll just go ahead.
And sarcoid we are not considering there are no lymph. I don't think there were significant lymph nodes.
There were no
Is-
significant perihilar lymph nodes actually.
And lymph nodes we can be part of reactive. And E7C, it's always like not a specific test and always gives a.
Yeah, exactly. And it was not even significantly elevated also. Like it was hardly elevated.
I think what are guidelines have thought that age should not be done acute. Yeah, actually misguide you actually.
Yeah.
There are a lot of misinterpretations of overdiagnosis.
Exactly. Because ACE can be elevated mildly in many other diseases. Exactly.
Second, definitely variability that Sangeeta said,
Hmm.
this reactive lymphadenopathy,
Yeah.
because she had some sort of diet, white pains. Autoimmune syndrome that she already pointed out that in any patients you have to rule out because you have a node. Right?
Exactly.
So definitely you have to have had the biopsy at point. If it comes out to be reactive, then definitely we could think of it autoimmune syndromes. And let's see. And regarding this PET CT, because previously in the comparison, in the previous edition it was said that CT followed by PET. Now they reversed it.
Reversed it.
So they said the comparison said that you should do PET in the PO, then CT. What is this thing? Because now in India also because it was very expensive at the time. PET CT was not available at that time. So we have got diagnosed CTs there. But now PET CT are available and the cost has actually come down. But still, PET is
But the problem is
more
the patient also gets a little, it was a young patient. Yeah, maybe. Now in retrospect, I feel the PET should have been done before. Except the CCT, all the other things would have to be done either ways. Like
PO PET would be because you can have a tissue thing that
either ways, the tissue diagnosis has to be done. Whether we do the PET or the CCT, tissue diagnosis has to come.
Any one of those differs from it, PET CD or CT PET? Any CT for the PET? Still. Yes, yes. We have done this.
I'll personally tell you, I have seen a few cases. I don't know for whatever reasons, the PET has misdiagnosed. Misdiagnosed in the sense, it has given colonic, the increased FDG in colon. And you go in, you tell the patient that, oh, there's going to be something, and then we do a colonoscopy, and it comes out to be normal. For whatever reasons, maybe not PUO, but a GI bleed or a GI inflammation, and we are highly suspecting something. We going for a PET CT, and it shows increased uptake. We going for a colonoscopy, and there's nothing. For whatever reasons, I don't know.
I differ a bit because the cost, we are into the cost. We are doing a CT that will cost around
8,000, 8 to 10,000, yeah.
No, we are doing chest and abdomen, so more than 10,000, and PET is now, I think, available for 10,000. And then we are increasing the radiation, double the radiation, and I have picked up very vasculitis, especially in elderly, large vessel vasculitis, giant cell arteritis. We commonly see CT is not normal, then we do a PET scan, then we find
Vasculitis.
aortic thickening or so. I think young people it might differ, but more and cost effective also. And radiation or exposure is also like we are cutting down. Otherwise, you do a PET now, so it's double the exposure.
Actually, we are all learning it. We are all in the learning phase. Because it's a subjective, like what the doctors are thinking about. क्या सोच रहा है?
Well,
Because हिंदुस्तान में अगर fever आ रहा
उस समय it was TB going on in the mind, So that is going in that mind, At that time, you feel high grade fever. Maybe, And तो था घर के आसपास, and then you say, oh, maybe she's, so you sort of.
मुझे तो सोच रहा है मैं बोला कि PET पहले कर लो and then maybe plus minus CT बोला है उन्होंने. But I think PET will give you lot of detail.
And at that time, you're not thinking of the diagnosis which you know, you know. We all unique. For me as a physician, when I got all the inflammatory markers done and it was all negative, so this is not what I was thinking of at that point of time, you know. Huh. Because as a rheumatologist, you're thinking of something else. For me, that diagnosis was the last diagnosis.
Same patient PET scan to cancer का सोचेगा.
Exactly. For him, it is whenever you say PET, the first thing the patient thinks, oh, ma'am, आप cancer surgery हो. And I'll tell you something. Actually, after the PET, actually even after the done, we were thinking of malignancy first, and the hematologist actually came and said it is cancer. And the patient, literally, the patient and the family members are crying. And chalo, I'll go ahead then. So then we planned a true cut biopsy. And actually, the true cut biopsy was a little misleading for us. So the true cut biopsy showed us some ill-defined epithelioid cell granulomas with a few macrophages and some reactive histiocytic cells, no definite Reed-Sternberg cell, no caseation. So there was no caseation, there were no Langhans cell, giant cells. So it was a little non-specific, but they said they were granulomas because I spoke with the pathologist and she said that I think it's tuberculosis. And they sent a report that is highly suspicious for tuberculosis. And between the true cut biopsy and we sent a gene expert that came negative. So with this report, I was not convinced that it is TB. And in between these two periods, when we took a true cut and this report came, since the patient was persistently having high grade fever, I gave her a shot of steroid, just a single shot of hydrocortisone 100 mg, because the fever would not touch normal and the patient was frustrated. Just a single shot and the fever settled for 48 hours. So this is the period when this report came. And I told the attendants that, see, this is not TB. We need to go in for further testing. We need to get an excision biopsy done. We need further testing. But because the fever had settled, they were very, very much, happy. And they gave a consent for empirical TB. We took a consent for empirical tuberculosis because I was sure that this is not tuberculosis. There was no caseation necrosis. There was no Langhans giant cells. This was not TB at any cost. But because they were not, we tried to explain it to them every way possible. So then we took a consent and we sent them on empirical ATT. Within 5 days, the patient was back.
Dr. Nita, what is the take on seeing this report with non-cystic myeloma and gene expert negative?
Because this could be sarcoid also. This could be anything. Dr. Anvita, so what do you think with this true cut biopsy report?
So axillary lymph nodes is the main tricky thing, that even though axillary lymph nodes are enlarged, more than often they come out to be reactive. So although we are tempted that it's a peripheral site, it often leads to an inconclusive biopsy. So as you rightly pointed out, ma'am, this is not a definitive report. We would have to repeat one. This really doesn't give us any headway. All it talks about is granulomatous etiology, but which type, which kind, it's not clear. Even though sometimes gene expert might come negative in axillary lymph node biopsy, more than often we've seen that these patients would have mediastinal lymphadenopathy, which can turn out to be either even lymphoma, sarcoid, or TB later on. But axillary lymph nodes might not yield much. So it wouldn't really clinch our diagnosis at this point with this, ma'am.
So then the patient got readmitted with the same complaints, the same persistent high-grade fever, with a little more of joint pains because maybe she was on ATT and she was on pyrazinamide. Then we went ahead, full-fledged, we got a PET CT done. We got a bone marrow. We involved the hematologist after the PET CT because still we were not suspecting an autoimmune disorder somehow. So this was the PET CT. So the PET CT again showed PET CT showed increased uptake in the lymph nodes with a increased uptake in the bones also. So the PET CT showed metabolically active cervical, mediastinal, axillary nodes and diffuse splenic and bone marrow hypermetabolism, which could be either a reactive or a lymphomatous involvement. So then we went ahead with uh, a bone marrow biopsy, which the hematologist done with a bone marrow flow cytometry and a lymph node excision biopsy. The lymph node excision again was difficult because her axillary lymph node was very deep. So that was again a challenge. So the bone marrow came histology, I mean bone marrow biopsy was normal and the bone marrow flow cytometry was suggestive, was normal, and it just showed leukocytosis. So this is the point where for me I almost was sure now that the diagnosis is, I knew that the lymph node would also be normal. That is when I was sure. And then the lymph node showed lymph node biopsy came as normal with a preserved germinal center follicles and foci of sinus histiocytosis. And the EBV, we had sent it to Rajiv Gandhi, the pathologist was known to us. So he did a EBV for us and he said if it comes positive, you would charge. The EBV was negative. So now Sir knows.
Actually, the case, first of all, it's a fantastic case going round, here and there, everywhere. So, once actually, from the beginning till this slide, actually, I wanted to summarize in one line. Actually, the patient with PU with neutrophilic leukocytosis and and significant joint pains and the period is
The
not.
joint pain was not very significant. Again, it was just a pain which appeared only during fever. That was again a little misguiding for us because for us, the joint pain was again had to be elicited out. Her only problem was fever with chills and weight loss.
So, but pets can show lots and lots of take and all these things. So a hematologist for sure would be thinking there is a neutrophilic leukocytosis and a possible nerve movement. It can be an MPN, myeloproliferative neoplasm can be
Yeah,
or CML can be a differential.
exactly.
But the base of this one never increased. So other sorts of MPN like sometimes polycythemia vera, essential thrombocythemia. All these mutation workup can be done to just make sure that we are not missing anything. And secondarily, in bone marrow biopsy, actually we always need to get a fibrosis assessment done to bone marrow biopsy with reticulin stain to just make sure that there is no secondary fibrosis which is causing pain. And the patient is having neutrophilic leukocytosis, fibrosis is secondary to some mutation, and myelofibrosis is going on that causes pain, fever, neutrophilic leukocytosis. So MPN is a differential.
So the bone marrow biopsy was done by the hematologist. So I don't know. He commented on it that it was normal. It was taken by the hematologist, and after 2 days, he said it's normal. So I don't know. I am not a hematologist. I'm a physician. I took his opinion. He said it's normal.
So yes, we can go ahead with the treatment and that.
I didn't plan the treatment. I just handed it over to the rheumatologist after that. So this is the biopsy report. No evidence of well-formed granuloma, no evidence of malignancy or a lymphoproliferative disease. So the positive findings were just fever, arthralgia, lymphadenopathy, and an evanescent salmon pink rash. And the positive finding in the pathology was anemia, leukocytosis, that is neutrophilic leukocytosis, high ferritin, high CRP, lymph node with foci of sinus histiocytosis, a normal bone marrow, a normal ANE, and a normal RA.
Right, so I think Devansh said that the diagnosis is children. So firstly, we are dealing with autoinflammatory syndromes. Okay, and I think this is one of the differential would be thinking of.
Students, I think it's very clear it is adult onset skin disease.
Yeah.
Criteria.
Yeah. So it is an adult onset Still's disease. Adult onset, when the onset is after the age of 16 years, it's called adult onset Still's disease, fatigue, muscle pain, fever, weight loss, poor appetite, lymph nodes, sore throat, rash. She didn't have arthritis. She had arthralgia. We had a knee joint X-ray done. She didn't have arthritis. And, oops, sorry. Yamaguchi criteria. So at least 5 criteria, out of which 2 major. So major is fever, arthralgia or arthritis of more than 2 weeks, a typical rash which she had, a WBC count of more than 10,000 with 80% neutrophilia, and minor criteria: sore throat, lymphadenopathy, hepatomegaly or splenomegaly, abnormal LFT, negative ANA and RA. Investigation: CBC, LFT, inflammatory markers, ferritin, triglycerides we did only after the diagnosis. And workup, we have to exclude alternative infections, malignancies, and autoimmune etiologies. So that has to be excluded. And the treatment, of course, after diagnosis, we involved the rheumatologist. She was given pulse steroids, and then she was on steroids and methotrexate, and she didn't respond well. And then I think now she's on biologics, and she does talk to us. So you should.
I don't think this is requires pulse steroid. Usually, we are now more shifting towards oral steroids. And
She
I
was
think
given
hence
3 days of pulse and then shifted to oral steroids.
I avoid high dose steroids. So what I follow is I give NSAIDs also along with.
She was on
Steroids.
NSAIDs, but she was continuously having fever despite that.
So I'm so the what I do so I start with steroids, NSAIDs, and methotrexate,
Mm.
and I think 90% of patients they respond, and if they do not respond, then I think the go-ahead drug is IL-6 inhibitors, which is tocilizumab. So I have 5-7 patients currently who are on tocilizumab. I do improve. I start with 40 so I don't give high dose 30 to 40 mg depending on weight, and usually people respond to 30 to 40 mg steroids. So if they do not respond, then I always counsel for IL-6 inhibitors. Many of them do not afford it. So now of JAK inhibitors are also good drugs.
I
And
think
some of
she's
them-
on IL-6 now. She came around 3-4 weeks back. They were planning on IL-6.
They are giving IL-6 inhibitors.
I think now because she's known to an RMO in my hospital, so I'm getting indirect. So I think she is now on IL-6 because she continued to have fever on and off, breakthrough fevers, and her inflammatory markers remained high. So I think they shifted her on IL-6, but I haven't seen her for almost a month now. So.
Having bone marrow, I think this is the classical finding we usually see in Still's disease, hypermetabolic bone marrow intake as marrow skeleton.
Yeah.
And I remember a case in Apollo, very high profile, my senior Dr. Handa. So we did bone marrow twice. So I was very skeptical from AIP patient. And so this was the finding, and patients, they were taking multiple opinions. So some were saying there is a hematological malignancy for sure. But then we did bone marrow twice and it was all normal. And I remember that patient was at tocilizumab for almost 3 years. During my entire residency there. So,
Yeah, that's something.
but it's like autoimmune disease, so long-term treatment. So I think it behaves like rheumatoid, but they have remissions in between. So say they spontaneous remission, and usually it's monophasic. Once it remits, but I'm seeing a lot of patients they're vaccine and then we use for biologics. They remain okay for a few months, then they again develop fever. So there is no set protocol. Polyphasic is very common. Monophasic is very common. So prognosis is by and large good. But they have to be on medicines. It's a chronic disease. So I always explain that it can relapse anytime and you have to be under observation.
So it was a good case for us. And the best part is the patient, sort of stick with us throughout that period. So,
One question regarding motherhood. Any
Yeah,
advice has to be
pregnancy
given?
again would be because she's just 22 years old and
Will she be able to bear children? Maybe
that will depend on the drugs.
But what advice have you given?
Sir, I have handed the patient over to the rheumatologist. Now he has to tell
Indirectly. Yes, so anyway, for the discussion's sake,
No, so I've not seen such a young girl. I have seen more in males. Their pregnancy has been not. I mean, family planning has not been a problem. But then I think we have options like azathioprine, tacrolimus. They have all been tried and successfully. So steroids will be given in pregnancy, and I think conceiving should not be a problem. Lupus we regularly they conceive. So we see young girls conceiving. I think SL is more dangerous than stills. You have renal involvement, you have neopsychiatric lupus, and successfully planning families. So the drugs have to be modified, and maybe the patient will need more steroids during pregnancy, since we cannot give IL-6 inhibitors, we cannot give JAK inhibitors. So drug options are limited, but somehow I think it can be managed.
Besides, ferritin बहुत high है.
Thousand-
Thousand छोड़ दिया they have
I think it's sufficient.
yeah.
I see normal ferritin with Still's disease. I have a young, he was admitted in Max for I think 10 days. So 3-4 physician के बाद मेरे पास आया तो I see a filtered cases, so it's life is much easier, but I think उनका ferritin normal था. There was a case Still's है या malignancy है या hematological malignancy. So I think bone marrow should be done in all. I always advise hematologist के ऊपर अगर वो एक्सक्लूड कर देते हैं कि नहीं malignancy नहीं है तो I am happy. क्योंकि कई legal dilemmas कोई क्या है कि malignancy नहीं भाई
So basically to rule out everything.
everything.
Do a polygraph study directly. जैसे कि सर ने बोला कि you have to do a polygraph study of the marrow और सारी माइनर malignancy का पहले ही भेजना पूरा DNA और एक कोई
So what can we do? We used to say there is no malignancy, no need, so I was okay with that. So I cannot take that.
मैं थोड़ा एक्चुअली ना ज्यादा थोड़ा ओवर उस पे रहता हूँ कि मैटर
सब ऐसा है. आप बोलेंगे ना ये निकालो वो निकालो पेशेंट का ये
but then
Disease of exclusion because
Exactly.
yeah, it is always a disease.
you have to rule out everything like infections.
Infections and bone marrow and hematological malignancy must be excluded.
The first thing on seeing the PET is you feel it's a malignancy.
It doesn't look like you're presenting for the first time, right? अरे ऐसा केस गुड ऑनर बहुत नोट किए मैं समझे तुम्हारे वो फ्लावर भी
I request Dr. Srivastava to kindly come over to the stage. Also thank Dr. Anvita for the inputs. So after this wonderful discussion, now we'll go ahead with our second presentation, which is an interesting case of fever with pancytopenia. Presenter is going to be Dr. Rishabh Thakur, DNB resident Max Vaishali. This case is going to be moderated by Dr. Ashish Gupta, Associate Director, Max Vaishali. And it is going to be chaired by Dr. Sushil Kumar Tyagi, Consultant Physician, Yashoda, and Dr. Rohit Kapoor, Consultant Hematologist. Max Vaishali. I request Dr. Start with the presentation.
Anvita, are you there? Anvita?
Good afternoon, everyone. I'm Dr. Rishabh, and I'm going to be presenting a case of persistent pancytopenia in an elderly female. So, a patient, an elderly female of 75 years age, presented to our emergency. Her demographics were as mentioned. She was of average thin build, housewife by occupation, resident of Sahibabad, Uttar Pradesh, Hindu by religion. The patient presented to us with a history of fever, which had lasted for 10 to 12 days. And she also had generalized weakness, and due to this, she was unable to perform her routine activities. Fever was not very high, it was around 100 to 101 in peaks. It was relieved by oral antipyretics, not associated with chills, rigor, and there was no diurnal radiation. According to the history by the attendants, the patient was hearing and speech impaired since her childhood. So, due to this, there was a bit of a communication problem with the patient. The patient had consulted a local doctor. I mean, the attendants took her. Usual tests were done, and some oral antibiotics and antipyretics were given. Blood investigations were done outside, which were quite recent. It revealed pancytopenia with a hemoglobin of 4.5, platelets of 47,000, and TLC of 2100. She also received 2 units of PRBC transfusion at some outside hospital, but the documentation was not available with the attendants. Apart from this recent consultation and reports, there was no previous blood reports available. Though the attendant had given a history of some liver disease in the past, for which she took some treatment, but again, the reports were not there. There was no recent history of jaundice, thrombosis, cytopenia, any hematological condition in the patient or any of the family members. On admission, the vitals were stable. Pulse was bit on the higher side, 94, regular, normal in volume, no radial, radiofemoral delay. SpO2 was maintaining saturation on room air. Temperature, she was afebrile on admission. On general examination, there was significant pallor, no icterus, cyanosis, jaundice, clubbing, lymphadenopathy, or edema. Systemic examination revealed that she was conscious, and orientation could not be properly assessed. S1 and S2 were hurt. No, there was soft systolic murmur. Respiratory system was normal. There was no adventitious sounds. Abdomen was soft. Bowel sounds present. No organomegaly. In personal history, there was no smoking, alcohol, drug abuse, no high-risk behavior, or known allergies. So till now, our clinical impression was as some acute febrile illness with pancytopenia under evaluation. Next, we did some tests of our own, which came out as hemoglobin was 5.6. MCV was a bit on the higher side, 105.6. TLC was again low, 2,900. Platelets were 10,000. First day of admission, we got the reports for dengue, malaria, typhoid, Vidal. These were all negative. B12 was on the higher side. Peripheral smear revealed pancytopenia with macrocytic anemia. INI thyroid profile were all normal. Urine routine were normal. After these tests, we did some additional workup. Kala-Azar, ANA, Coombs, these were all negative. ANA by IF was negative, but in ENA we got anti-SSA positive. Reticular site count was 3.5 elevated. LDH was 225 slightly elevated. And the cultures were all sterile. I mean, blood and the urine cultures were sterile. Radiological investigations, the initial ones, ultrasound, whole abdomen, and X-ray, they revealed no significant abnormality. Patient was started on IV antibiotics and had blood products transfusion, that means platelets and PRBCs. So, since the attendant gave history of some liver disease, so our diagnosis till now, clinical diagnosis, pancytopenia with macrocytic anemia, query aplastic, query MDS, query autoimmune, CLD. So next we did the CLD workup. Fibroscan was done, but it was normal. In view of SSA positivity, we took a rheumatological consult, but they from their side there was no active intervention because there was no other features of some autoimmune disease. In view of persistent, but the pancytopenia remained persistent even on subsequent tests. So for that, we did some bone marrow and aspiration and biopsy, and they were also sent for cytogenetic study, myeloid and leukemia panel. The aspiration showed smears were markedly hemodilated and pauciparticulate. Erythroid precursors were prominent and showed normoblastic maturation, mild megaloblastic changes. Scattered myeloid cells were showing complete maturation up to segmented neutrophils. And there was no increase in blasts in the cell population. The bone marrow biopsy, it revealed a normocellular marrow. The bone architecture was preserved. There was erythroid preponderance. Granulopoiesis was reduced, but again, complete maturation was seen up to the segmented neutrophils. Predominantly normocytic maturation of erythropoiesis was seen with mild megaloblastic changes, as mentioned before. Some rare megakaryocytes were seen, scattered lymphocytes and plasma cells. But again, there was no blasts here. So these are the usual causes of pancytopenia. Again, hematology opinion was taken because of persistent pancytopenia and inconclusive bone marrow reports, and patient was also advised for flow cytometry. On stabilization, she was discharged with close follow-up to follow up with the flow cytometry reports. Labs on discharge, she had hemoglobin of 7.9, PLC of 3200, platelet counts were 65,000 on discharge. Just 2 days post-discharge, she presented to us again in the emergency. Now she had complaints of perirectal bleeding. So on examination, she was conscious, vitals were stable. There was again significant pallor. Investigations revealed a drop in hemoglobin of 7 to 7.2. Platelets were 25,000. Again, we had repeated transfusions of packed blood cells and platelets.
Dr. Robin, do you want to comment anything at this point?
The key thing that Dr. Rishabh said that the bone marrow, actually he met me in the stairs actually. We were seeing different patients and he just collided with me and he asked, we have a patient, we have this, and the marrow looks absolutely okay. Then he sat up with me in the computer and I read each and every line and explained him the meaning of each and every line of the marrow. So I told that there is one thing which is mentioned in the marrow, it is known as erythroid hyperplasia. Means erythroid compartment is functioning very good, but the outside, nothing is coming up. All the cell lines are down. Okay. And, so I told that sometimes, it can be a component of a B12 deficiency. And in PNH, the first thing that we tend to see is erythroid hyperplasia in the marrow. The marrow does not tell anything in the PNH. Then you have to do a flow for the certain things actually to basically diagnose certain disorders of flow cytometry is the pinching thing sometimes in these conditions.
Given the rectal bleeding was ongoing, the episodes were ongoing, so gastroenterology opinion was taken, and she was advised for colonoscopy. Colonoscopy was done. It revealed a rectosigmoid mass, along with a colonic polyp and external hemorrhoids. So the biopsy from the rectosigmoid was taken, and it was sent for histopath examination. In view of this mass, some tumor markers were sent, CA19-9, CEA, and AFP. Only CEA was a bit raised, 26.77. In view of the elevated tumor marker and the rectosigmoid mass, we decided to do a contrast-enhanced PET scan of the whole body. This revealed an FDG-avid circumferential wall thickening in the rectosigmoid region. It was of 5.8 centimeter in size. There was some perilesional fat stranding and multiple mildly avid, FDG-avid and some non-avid subcentimetric lymph nodes were seen. But there was no other FDG-avid lesion in rest of the body. Meanwhile, we received the histobiopsy reports of the rectosigmoid mass. It revealed features consistent with intramucosal adenocarcinoma. So here our provisional diagnosis was adenocarcinoma sigmoid colon, but with no marrow infiltration or distant metastasis and pancytopenia. We still don't know the cause.
This patient have a diagnosis of pancytopenia. The fever patient responded to fever after 2 days of admission. She didn't have any fever, but persistent pancytopenia was our issue, for which we had Dr. Rohit, and subsequently the flow cytometry report came in during the second admission.
So meanwhile, we received the reports for karyotyping, the flow cytometry, and the comprehensive myeloid leukemia panel. There was some variant of JAK2 gene, but it was of unknown significance. So this was not conclusive. Cytogenetics revealed a normal female karyotype. No numerical or structural abnormality was detected. And the flow cytometry, it revealed minor PNH clones in RBCs, neutrophils, and monocytes in all of them.
So, they had a very big round conference meeting. What is going on? What is hanging in the marrow? It is likely infiltrative disorder. So finally, we came out with a very rare diagnosis. After the team discussion. In fact, the patient, we saw that it is a minor PNH clone. What will minor PNH clone do? But actually, whatever the clone it is, major or minor, if the pancytopenia is there, you have to treat it. Okay. And the key thing is the minor PNH clone can also cause like aplastic anemia, and the other type of clone is a major clone, in which the GPI anchored clone, the mutation is more than absence of GPI anchored is more than 30%. So in that, hemolytic PNH is much more common. In less than 30%, the PNH clone is present, and it is most likely a aplastic kind of PNH. So this clone was entering with the normal hematopoiesis, and there was no practically infiltrative disorder of the marrow, which was like the rectosigmoid causing infiltration. We were thinking. So the management is totally different. It depends on the aplastic clone or it's a hemolytic clone. So generally, major clone behave more of a hemolytic like clone, and minor behave more of aplastic kind of.
So for now, our final diagnosis was pancytopenia with acquired bone marrow failure with associated PNH, minor clone, and rectosigmoid adenocarcinoma.
The adenocarcinoma did not contribute even slightest to the cause of pancytopenia, as evidenced by the PET-CT. It was not infiltrating localized disease and marrow damage.
So basically, what happens here is there's mutation in the PIGA gene, leading to the loss of GPI anchored proteins. So how do we evaluate a patient with where we find a newly identified PNH clone? First, we have to review the flow cytometry reports. So we have to see what's the sensitivity of the assay. Are 2 or more markers used? Were both granulocytes and red cells evaluated? And what are the clone sizes in different lineages? And again, we have to do an evaluation of the underlying bone marrow failure, as bone marrow aspiration biopsy cytogenetics have to be done. And obviously, we have to take a very thorough history of cytopenias, prior diagnosis of aplastic anemia or any hematological conditions, history of ischemia, thrombosis, transient ischemic attacks, or any features of hemolysis. And the usual laboratory studies, they definitely have to be done: CBC, LDH, absolute retic count, haptoglobin, bilirubin, ferritin.
The NP is for normal 220. There was no evidence of any hemolysis.
So there is an article by the American Society of Hematology titles "When does a PNH clone has a clinical significance?" So the connection between aplastic anemia and PNH is that PNH arises from acquired PIGA mutations. 46% of acquired aplastic anemia patients, they have a detectable PNH clone, but the majority are their small subclinical clones. And why do these appear in aplastic anemia? T cells mediated, why are they present? T cells immune attacks, they target the normal hematopoietic stem cells, but these GPI deficient clones, they evade the immune restrictions and there is some relative clonal expansion. And now they can be detected. Clone sizes are usually small in A. So in patients where we are finding PNH clones, we can broadly classify them into 3 groups.
For the clinical presentation, how PNH patients can present in 3 different ways. First, I would like to say it's a classical PNH which everybody knows, Brexpiprazole alternate hemoglobinuria, in which patients have hemolysis and thrombotic episodes. They usually present with large clones, in 50%.
And obviously the features of hemolysis and laboratory markers of hemolysis are present. And obviously there is risk of thrombosis. On the other extreme, there are subclinical cases, which are the majority of the patients. The PNH clone is less than 30%. There is no clinical hemolysis. Laboratory markers may be present, depends on the clone size, but the risk of thrombosis is very low. And in between, we can also have some symptomatic patients where there is moderate clone size, and they may have clinical hemolysis, and there is intermediate risk of thrombosis. So this graph, it depicts the bimodal distribution of PNH clone sizes in patients' clinical presentation. On one extreme, on the left side, we see bone marrow failure with associated PNH clone. That is the minor clone. And on the other extreme, the blue side, we see that is actual manifestation of PNH, the patients who are having hemolysis, having thrombosis. Yeah. Management implications. When do we need a complement inhibitor therapy? So if we don't need that. If there are no features of hemolysis, if LDH is almost normal, if it is a minor PNH clone, and we have to treat the underlying anemia. We have to give immunosuppressive therapy plus L-Thrombopag, hematopoietic stem cell transplant if indicated. Minor PNH clone is actually good because it shows there's better response to immunosuppressive therapy, lower risk of progression to MDS. But the clone has to be monitored yearly because it may persist, it may shrink, or sometimes rarely it expands, so it requires monitoring. So annual PS flow cytometry has to be done in such patients. Aplastic anemia and colorectal cancer share similar symptoms like GI bleeding, which can cause delay in the diagnosis of malignancy. So thrombocytopenia, again, it exacerbates the bleeding risk. Management in elderly patients, cyclosporin plus L-Thrombopag, which we were using in this patient, it achieved 60 to 73% response at 6 months. And there are fewer toxicities than anti-thymocyte globulin-based regimens, making it ideal for elderly patients with comorbidities. Given the patient's profound bone marrow failure and there was transfusion dependence, there was a multidisciplinary approach which was taken, including the hematology, gastroenterology, medical and surgical oncology teams. Surgical intervention and chemotherapy, they both were considered high risk in such a patient. And also, along with discussion with the family members, it was decided to manage conservatively with blood products transfusion as and when needed, cyclosporine, L-Thrombopag. The patient was clinically stable at the time of discharge. She was discharged with regular follow-up and regular PRBC and RDP transfusion. Thank you.
This side was fantastic actually. This case was a very unique kind of case. The attendants, they practiced even to me in the OPD and they told, we have lots and lots of very expensive medicines like inclusive all these medicines. Why are not we giving all these medications to her? We'll fix some, this aplastic anemia, then we will, fix this adenocarcinoma. So I explained them that, first of all, it's a minor PNH clone. You do not have to go ahead with the hemolytic therapies, like which prevent control hemolysis. So in minor PNH clone, you only have options of L-Thrombopag as well as cyclosporine. ATG in elderly frail, she would be septic. Okay. So even if we treat and even if we increase neutropenia, hemoglobin, platelet, once she'll get chemotherapy or radiotherapy or surgery for adenocarcinoma, again the counts will go down. So she's practically not a candidate for chemotherapy later on after the treatment. So that's what we told her to think of future, that you cannot, treat. This is more of a palliative case, because if we treat adenocarcinoma, eventually if she gets chemoradiation, she'll become pancytopenia, and she's already pancytopenia. So it's a roundabout cycle. And the key thing is the patients do come of the patients, young patients also come with PNH. Actually, have transplanted recently one patient with PNH. He was a young patient, and he had also a minor PNH clone. He already had thrombocytopenia. His hemoglobin and TLC was absolutely okay. He had history of smoking. No features of any kind of thrombosis of blood in the urine, like in the classical PNH it happens. LDH was also normal. So he also had a minor PNH clone. But the best treatment, earlier you treat, because the key thing is eventually it will accumulate more cytogenetic anomalies. Like JAK2 is there, one cytogenetic anomaly is there. If one more cytogenetic anomaly is there, it will turn into MDS or AML. So JAK2 can be in AML, it can be in MDS, it can be in MPN, myeloproliferative neoplasm. So one more hit, it means she becomes a leukemia. So in younger patients, if the patient is diagnosed with PNH or minor PNH clone, best to, if there are no comorbidities, go ahead with the hematopoietic stem cell transplant and fix the stem cell issue from the base. So the outcomes are pretty good. If there is no history of thrombosis, if there is no history of any kind of comorbidities like this patient had, then outcomes are very, very good. Maxillary donor transplant is one of the best in the PNH. Main thing in the transplant patients of PNH is development of liver dysfunction or VOD, because they have taken sometimes hemolyzed during the phase of engraftment. So the PNH patient, correctly said by you that the monitoring, the PNH clone should be monitored even after transplant, like around 60 days after the engraftment is done, if the PNH clone is coming back. So the patient can relapse even on the after the transplant, and you have to monitor by clone, like you do in this case, to see the clone size. If it is increasing from 10, 20, 30, 50, 50 means it becomes hemolytic. You manage hemolysis, complete hemolytic, and aplastic PNH like aplastic. So this is what the key thing is.
So it's a very rare to presentation of pancytopenia. We unusually see this type of patient. We usually see pancytopenia. I think most of our physicians see pancytopenia. The cause comes out to be the nutritional deficiency of B12 or folic acid deficiency. So I want to know, Dr. Rohit, what should be the indication for doing bone marrow examination and biopsy in cases of pancytopenia? When to suspect other things except this nutritional B12 folic deficiency?
So the bone marrow examination, whenever there is bicytopenia, and if you have already depleted B12, iron, and you have given lots and lots of hematinics, and the patient is not improving, and the reticulocyte count, which is the poor man's bone marrow, it is not increasing. So once you give B12, iron, folic acid, even if the patient is not agreeing for marrow, you do two tests, LDH and the retic. If the LDH normalizes or retic does not increase, then there's some sort of a marrow failure. So these things plus we can also, before doing marrow, we can do a direct stool test, so that there is no hemolytic anemia. Even if it was in hemolytic anemia, there is electrolyte hyperplasia. In this case, as Dr. Rishabh said, that BCT was negative, LDH was marginally raised, and retic was not raised. So it is a BCT negative, like kind of anemia, and reticulocyte count response is not raised, then for sure we need to do a marrow. There is, we have to suspect a marrow failure syndrome. So depletion of iron, folic acid, B12, and then if it does not improve within 14 days, then go ahead with the marrow. It commonly happens in MDS, myelodysplastic syndrome. The patient is getting lots and lots of iron. 3 months got iron. Iron stores of the marrow are 4 plus, whole same, and the patient is not having increased blood count. Then the MDS and MPN and the PNH and acquired plastic anemia has to be thought in. So this case actually, Dr. Rishabh, always came to me for the follow-up, and he had a very intellectual discussion always. I told him, always once you have a electrolyte hyperplasia in the marrow, you always get an NGS done. You do have to get an NGS, because we ordered NGS later on. It was not from marrow, it was from peripheral blood. So it did pick up mutation, it is JAK2. So it means, if her condition worsens, we already have a background mutation of JAK2, and if her pancytopenia worsens or hemolytic comes up, we again have to send off new NGS to see what is the VAF, what is the variant allele frequency. If the variant allele frequency is high, then we have to treat. If there is a new mutation and VAF is more than 10%, then the diagnosis changes. Means it's an evolution of from PNS to MDS or AML or whatever malignancy. So the key thing is the PNH will not always remain PNH. It's a pre-malignant condition and it can turn into MDS or AML. So whenever the symptoms increase, you again have to order a myeloid NGS leukemia panel to see a new mutation. You have to see the VAF, and VAF is more than 10%, and it means the new significant mutation has come up, and then you have to treat. And the diagnosis will change as per the WHO classification. So it is the way.
Satya? Already. Thank you, Rishabh, and thank you for wonderful case, and Rohit and Taggy. Excellent input from you. So I think we can close session and put on a
We have a few awards to be declared today. I pass on the mic to Dr. Pankaj.
Felicitation of our speakers and chairperson, just 5 minutes. And we are having our monthly EDP Champion Award, and this time EDP Champion Award is going to Prademanshu. Prademanshu is a young cardiologist from Max Specialty. And I think I request her newly wed wife also comes up. They are recently married. I think we should take applause for you. Congratulations. You can introduce the wife, I think. Thank you.
Everyone, good afternoon or good evening. I'm Dr. Sakshi, his wife, and ophthalmologist, currently pursuing my specialty in the St. Parvati Hospital, St. Anne's.
This time the champion award, I think, is being awarded, and Ketan is doing a good work with the young cardiologist, is doing a lot of good work, and recently has gone to Japan, I think, for the end of trial. Right? Just tell us about that.
We are giving the injection incretin. Basically, it's decided on the basis of patient's LDL level. So we have many studies coming up. Incretin is a drug which reduces the cardiovascular impact. The patient who are having a dyslipidemia. So we have already statins, then ezetimibe. Then there is a new drug also. We are giving map PCSK9 inhibitor. So incretin is also coming. Earlier we told that when LDL is more than 190, we should give it, and patient is not controlled the statin. Now we see that patient is having MI and his LDL level are high, so we can give the incretin, and that reduces the chance of second MI and decreases the cardiovascular. The patients who are having.
Good work, and I request Dr. Ramesh Sharma. Dr. Ramesh Sharma already knows we had a very good picnic at his farmhouse, and he is running a good hospital here, Arogya Hospital. And I wish to festivate our champion award for this. Before we festivate you, moment off. And continue good work to. So we had a very excellent, successful EDP con. Successfully held at Liberty, and I think you are all this attendees. So we had a poster program, and two of the candidates have won the second and third prize. So first prize is already gone, and I think they were not available. So we took this opportunity to give this award. The second prize for posters was is being awarded to Dr. Nihash. Please. I request Dr. Vikram to come on to the state. You have the trophy and certificate. Let me over to Dr. Finisha. About 30 agents are my question.
I request Dr. Mukesh to kindly come and felicitate presenters.
Sure.
Moderators.
Yes.
Doctor Pratap Yadav, everyone.
Thank you all for contributing to this scientific session. See you all in the next meeting.
We are calling a picnic also, so maybe the detail will be shared very soon. Family picnic. Thank you, Dr. Piti, for very, very good case.
Anybody I met it or nice to see you. Here and the intellectual she was Yeah.